We're continuing on today with the acid-base sessions. I have some interesting cases. So here's a 83-year-old female with a 4-day history of chest pain in 2 weeks, worsening, short of breath and weight gain and edema. And she's CKD G3A3 with a history of hypertension and NSAID use, chronic hyperkalemia, osteoporosis, GERD. And on exam, the blood pressure was 150/79, O2 sat 92. JVP was elevated, and respiratory rate was high, bilateral crackles, 2-3 plus edema of the legs and tender right chest. Chest x-ray showed bilateral pleural effusion and some fractured ribs, and the patient was on a number of medications shown below. So here are the numbers. There's 3 sets of numbers, number of weeks before the first column, and on the right column is the day of admission. So the patient had some hyperkalemia in the past. Note that the total CO2 was 27, maybe a little bit elevated, and there was some drop in the eGFR, and the UACR was 400. And as you see, as time went on at admission, the total CO2 was 46, and the eGFR had improved a little bit. Note that the urine chloride was 95, and these are the gases below. The pH was 7.55, PCO2 52, and the bicarbonate was 44. So does anyone want to unmute and tell me what you think is going on with just the acid-base numbers? So again, remember, start with same thing as always, is the bicarbonate or total CO2 if you want to use that, normal, elevated, or decreased, and then go on from there. Anyone? No one wants to take a stab at it?
I just jumped on, so
sure, go ahead.
let me just take a look really quick.
Yeah, sure. So we're focusing on the last column where the total CO2 was 46, and okay, the blood gases are shown below.
So in terms of, just starting with the bicarbonate as we usually do, it being 44, that's already giving me an indication that there is an alkalotic picture here. And then I'm sorry, you're saying like compared to the serum specifically?
No, I'm just saying we can either look at the bicarbonate or total CO2. But remember, when you look at the bicarbonate and it's elevated, you don't equate that with metabolic alkalosis. It's always one of 3 things. We're going to say this every week. So if the bicarbonate is 44, there's one of 3, it's elevated. And there's one of 3 possibilities. It's either a metabolic alkalosis, as you were, I think, alluding to, but what are the other 2 acid-base disorders that can also raise the bicarbonate or the total CO2?
So it's either going to be that, it could also be a compensatory mechanism going on that could be chronic, or a compensatory mechanism that could be acute for hypercapnia specifically.
Okay, so again, the terminology is it's either acute or chronic respiratory acidosis. So that's the term you should use. And when we say acute, we're saying it's not compensated. So remember that acute respiratory acidosis and alkalosis have nothing to do with organs. That's just the bicarbonate buffer system. It occurs in any aqueous solution. If I bubble water or blood with carbon dioxide, I will get an increase in bicarbonate of about 1 milliequivalent or 1 millimole per liter for every 10 millimeters of mercury increase in the PCO2. Now, if it occurs for 3 to 4 days or up to 5 days, let's say, the bicarbonate keeps going up, and that's due to the kidney generating and reclaiming bicarbonate. But recall also, we don't use the word compensation. in respiratory acid-base disorders. We only use the English word compensation when we're talking about metabolic acidosis or alkalosis. With respiratory acid-base disorders, number one, we don't use the word compensation, and we distinguish the immediate change in bicarbonate, which again does not require organs, from the more chronic phase just by this temporal word, acute or chronic. That is a historic consequence of how the terminology evolved. So again, remember for the rest of your fellowship, do not use the word compensation when you're referring to respiratory acid-base disorders. And the other thing is, ideally, don't say hypercapnia, because hypercapnia really does not refer to the acid-base disorder. What you're saying there is that the PCO2 is elevated. And that could also be as a compensation to metabolic alkalosis. Remember, when you have metabolic alkalosis and it's compensated, the PCO2 goes up. That is hypercapnia. But that's not equivalent to saying someone has respiratory acidosis, where the elevation of the PCO2 is the primary cause. So again, it's always the same. And I ask you to memorize sort of the terminology in the words. If the bicarbonate or total CO2 is elevated, it's either metabolic alkalosis or acute or chronic respiratory acidosis. If it's decreased, it's metabolic acidosis or acute or chronic respiratory alkalosis. So here we have an elevated total CO2 was 46, the bicarbonate's 44. And that's about what you would expect the difference would be, because remember, the total CO2 also includes dissolved carbon dioxide, which is 0.03 times the 52, the PCO2 of 52. So if you take 0.03 times 52 and add it to the 44, you're going to get around 46. That's why there's this discrepancy. And that discrepancy increases the greater the PCO2 is. And the less the PCO2 is, those two numbers, the bicarbonate and the total CO2, get closer together. Remember that the total CO2 is mostly bicarbonate. Okay, so we have a patient here with an elevated bicarbonate, and now we have our three possibilities: metabolic alkalosis or acute or chronic respiratory acidosis. Remember, the acute and the chronic respiratory acidosis are number 2 and number 3 as far as the possibilities. So now we have to distinguish them, and we now look at the change in the bicarbonate from normality versus the change in the PCO2, because each of the three has a different change of each of those. So if it's metabolic alkalosis, remember that the PCO2 as a compensation, and again, we can use the word compensation there because it's a metabolic acid-base disorder. So the compensation is such that for every increase in the bicarbonate from its original level, the PCO2 goes up 0.7 of that, or 70% of that, or 7/10 of that, however you want to think about it. So it's a woman, so bicarbonate, let's say, started at 23, so it went up by about 21. We'd expect the PCO2 to go up 70% of that. You know, it's not exact, so it's around 14 or so, something like that. And now we have to think of what did the PCO2 start with? Again, it's a woman, so it's probably around 38. So if it went from 38 up 14, that's 52. So these numbers, before we look at the second and the third choices, are perfectly compatible with what you would write in the chart: compensated metabolic alkalosis. You don't have to think of anything else after ruling out 2 and 3. Now, we almost know a priori that 2 and 3 won't work, because it can't work for more than one of the three. And if the numbers fit any one of the three, they can't fit the other two by definition. But we'll go through the other two just as an exercise. So we know right now that these numbers fit a compensated metabolic alkalosis. Would they fit, just for a thought exercise, acute respiratory acidosis? Well, the rule there is that for every 10 increase in the PCO2 as the initiating event, the bicarbonate goes up 1. And remember, that's not a compensatory response. It doesn't require anything the body has to do. It's just bubbling a solution with carbon dioxide. Now, the buffer content has to be what it is in the human body. So if we had a solution on the bench with the buffer content and makeup of those buffers the same as the human body, if we could mash up the whole human body and take all the buffers and put it in solution, raise the PCO2 from 40 to 52, the bicarbonate would go up around 1, or 40 to 50. It goes up 1 for every 10 increase in this. So obviously this can't be what the patient has, because the bicarb is up by a lot more than that. It's up by 21 or so. Certainly not up by 1. And the PCO2 went up by, let's say, 14. So the bicarbonate should go up by 1.4. It should be 23 plus 1.4, which would be 24.4. And obviously it's not. So this cannot be an acute respiratory acidosis. Now we go to the third possibility. Could this be a chronic respiratory acidosis? Well, the rule there is for every 10 increase in the PCO2 is the initiating event, the bicarbonate goes up 3.5. So this went up by 12, so it should go up, 3.7, 3.8. Certainly it can't be. It went up a lot more than that. So, and again, we don't call that increase of 3.5 for every 10 a compensation. Again, we don't use the word compensation in the respiratory acid-base disorders, even though it is the kidney doing it. Technically we should, but it didn't work out that way historically. We just call it chronic respiratory acidosis. That's it. So
sorry, quick question, Dr. Kurtz.
Yeah, sure.
When you're saying that we don't use that, I'm just trying to make sure that I kind of fix the terminology in my own brain, because I feel like we've been going through it for so long in our training. We're kind of trapped in our ways.
You have to try to undo those neurons if possible.
Yeah, exactly. So I guess my question is, since you're saying we don't use the term compensation, would that be the case? Obviously, an acute makes sense, but would we say that even in the chronic setting?
Yes, yes. The correct acid-base terminology, you never use the word chronic in the respiratory acid-base disorders. That's the simple rule to remember. You only use that term when you're referring to what does the PCO2 do in metabolic acidosis, Winter's formula or 1-to-1 rule, whatever you want, or what does the PCO2 do in metabolic alkalosis. You only use it in the metabolic acid-base disorders, referring to what does the ventilation do as a secondary response. But you never use it in the respiratory acid-base disorders, either acute or chronic alkalosis or acidosis.
Got it. So I guess in that scenario, we would still be saying it would be like a superimposed, whatever.
No, you don't use the word superimposed. You never use the word superimposed unless you have more than one acid-base disorder.
Okay, I'm just what would be the proper way, I guess, to put it in terms of
so if you have a simple acid-base disorder, you never use the word superimposed. Superimposed implies two different acid-base disorders.
Okay.
And an acute and chronic respiratory acidosis is one acid-base disorder. And acute or chronic respiratory alkalosis is a simple acid-base disorder. I mean, if it's one or the other. You only use the word, and really we don't use the word superimposed anymore. You just say the patient has this and they have this. So they have a metabolic alkalosis that's compensated, plus they have an acute respiratory acidosis. You don't use the word, you don't say they have a superimposed. You're not saying anything when you say it's superimposed. It doesn't add anything to the diagnosis. It's much simpler to say they have this and this. They have both at the same time. Superimposed implies some human fiddling with it or something. I mean, it's a complicated word, superimposed. It doesn't mean anything. All you're trying to tell another doctor is that they have this acid-base disorder and they have this acid-base disorder. That would be the only context where you might think of using superimposed, when you have more than one. But I would get rid of that word also. You should never use the word superimposed. Just say they have this and they have this. Now, if they have a compensated metabolic alkalosis, or let's say this particular patient with an elevated bicarbonate, or they have an acute respiratory acidosis or a chronic respiratory acidosis, there's nothing superimposed there. It's superimposed, if you're going to use it, which you should never do anyway, is only used if you have more than one simple acid-base disorder. And acute and chronic respiratory acidosis are each only one acid-base disorder. I don't know if that makes sense, but.
No, that makes perfect sense. Thanks so much for explaining that.
Yeah, I mean, part of the goal of this series of talks is to rid your mind of a lot of the terminology that unfortunately different attendings use, and But they're not based on the terminology that has been accepted by. Really, it was Schwartz and Relman in the 60s and 70s that came out with how to analyze acid-base numbers and the terminology that one should use. The nice thing about it is once you rid your brain of all the extra words, you simplify your thinking. The goal here is to simplify your thinking so it doesn't appear as a big Rorschach test. If you just linearly go sequentially with the approach and you get rid of a lot of extra words, your mind will eventually, you'll feel less cluttered. It'll take time. It'll take probably 3-4 months, but just force your brain to get rid of the extra words, and in a certain sense, you'll be thinking more clearly, and you won't jump from one number to the other, and you can get mixed up that way. You should always have the identical approach to these numbers. It never ever changes. And once it's set and it becomes automatic, you'll see how easy it becomes. But it's hard at first. You have to undo a lot of thinking that you've had up to this point in time, but that's okay. So again, this could be one of the three because the bicarbonate's elevated, but the only change in PCO2 to change in bicarbonate that fit is a compensated metabolic alkalosis. So that's what this patient likely has. Again, we're assuming what the starting numbers are. We don't know that. We need that to get the deltas, or in other words, the difference from what it is now. And again, I'll say, you know, what I say each week. We did this without looking at the pH. We made an acid-base disorder without looking at the pH. So please do that. Just force your mind to only look at the PCO2 and the bicarbonate all the time, or the PCO2 and the total CO2, if that's easier for your mind. Usually, as I say, they're almost the same numbers, so it's not going to change your analysis. Okay. Now here, this would be true if it was a male. So it really is closest to a compensated metabolic alkalosis. Okay, so let's look at what's going on. Why does the patient have a metabolic alkalosis? And before getting into all this, does anyone here want to try to guess what maybe is going on? The clue is it has to do with the mag oxide, the calcium carbonate, and the sodium polystyrene. Now, typically, when you're getting Tums or mag oxide, if you take a ton of Tums, you can sometimes what's called get milk alkali syndrome, where you get a metabolic alkalosis from the carbonate, but it takes a lot to get that. It does occur more easily in someone who has an abnormal EGFR, because remember, the bicarbonate can't get excreted as easily. So for all the bicarbonate that's generated in the gastrointestinal tract, it stays in the body to a greater extent if the GFR is decreased. If the GFR is 0, it's all going to stay in. None of it's going to come out in the urine. So that is also contributing here. But the clue is the K-xylate that was given for the hyperkalemia. So this is what happens. The resin here is the K-xylate. If you don't have K-xylate and you're on mag oxide or mag hydroxide, in the stomach, you make mag chloride. Remember, the stomach secretes protons. Now, this patient was on omeprazole, which might have decreased that. In that case, it'll just go straight into the duodenum. But remember, in the duodenum, people know the stomach acidifies, less know that the duodenum alkalinizes. So the bile fluid is very alkaline. The bicarbonate can be 50, 60, 70 millimolar. It's very high compared to blood. So you have these two solutions coming into the GI tract, which are very interesting. The stomach, you have a ton of protons and it's a very acidic solution. And then it gets into the duodenum and you have this bicarbonate containing solution joining it. So the net result depends on the amount of fluid in each and obviously the pH of each. But what happens is you might make mag chloride initially in the stomach from the hydrochloric acid secreted, But in the duodenum, you have bicarbonate being secreted in the bile, and you end up converting it back to mag carbonate. Now, mag carbonate, it would be like taking mag carbonate instead of calcium carbonate, instead of taking Tums. Tums is calcium carbonate. Mag carbonate is the same thing except for the magnesium. Both of them can cause a metabolic alkalosis if they get absorbed enough, but it takes a lot. So the fact that you have this mag hydroxide or mag oxide converted to mag carbonate, you're not likely, unless it's a ton of this, going to get a metabolic alkalosis. Now, if you didn't have the hydrochloric acid secretion on omeprazole, you would still get mag carbonate made. So again, you have a compound that unlikely is going to cause a metabolic alkalosis. But what happens if you're on the Kxalate and the mag oxide or mag hydroxide? What happens is you get the resin with this compound in the stomach, and in the stomach, you make the mag chloride, you still have the sodium attached here. Remember, Kxalate is a sodium-bound cation exchange resin, and it exchanges with potassium, but it can also exchange with mag and calcium. So that's what happens here. Initially, you have the same thing as you had before, but what happens when you put this stuff in an alkaline solution? You end up getting mag attaching to the resin, and the sodium comes off the resin and attaches to the chloride. So you end up with bicarbonate actually in the solution. You don't have mag carbonate. You end up with sodium bicarbonate. And the sodium bicarbonate is much more absorbable than the mag carbonate was. Again, mag carbonate can also alkalinize. If you get enough of it, you will get a metabolic alkalosis, especially if you don't have a good GFR. But if you have Kxalate and you're on Tums, or Kxalate and you're on mag oxide, you have to be wary of a metabolic alkalosis. So that's, and the CKD, as I mentioned, prevents the bicarbonate from being excreted. So that's what happened to this patient. Now let's look at someone on Tums, calcium carbonate. Again, without the Kxalate, you make calcium chloride, but it gets converted back to calcium carbonate in the duodenum in this alkaline solution. Again, not well absorbed, so you probably won't get into trouble unless you're taking a ton of this stuff. But if you're on the sodium polystyrene, then the calcium will exchange with the sodium, and you'll get now net sodium bicarbonate generated in the duodenum instead of calcium carbonate, and the sodium bicarbonate gets absorbed. So the lesson from this patient is always be wary of someone who's on Tums, who's also on Kxalate. Now, obviously, it doesn't occur often. This patient happened to be hyperkalemic in that, so this happened to be treated. So this can be an exam question, but remember that the chance of getting a metabolic alkalosis was significantly increased here because, number one, the patient was on both of these things, and they had a lower eGFR. So for any bicarbonate that was absorbed in the duodenum, there's less of a chance of the kidney being able to get rid of it. Does anyone have any questions about this case? It's an interesting case. Anyone? Okay, so let's quickly go on to the next case. I did make a slide of how potassium also is involved in generating a change in bicarbonate, but I think we'll skip all this because of time. The bottom line is you should not be giving these things at the same time in a possible stop the resin. I mean, this patient was on 2 different compounds that can generate sodium bicarbonate in the presence of Kxalate. Okay, here's another patient, a 31-year-old female with nausea, pancreatitis, and hyperlipidemia. And there was severe dysnatremia. The total CO2 was less than 5, but on the blood gases, the bicarbonate was 20. Triglyceride level was 9,497. cholesterol was elevated, high VLDL. So this, it just is crazy. How can you have a total CO2 of less than 5 and a bicarbonate of 20? That would be the first thing that jumps out. And that's the point of this case. Does anyone know about this phenomena or have any thoughts as to what might be going on? Has anyone heard about this? How you can have this severe discrepancy? Okay, because this definitely could be on your exam and you really should know about it. So in the presence of high triglycerides, you get an erroneous measurement of the total CO2. And the bicarbonate is correct. So that's the teaching point here, that when you have high triglycerides, you get a spuriously low total CO2 measurement that's not real. And just getting back to the acid base, we can go back and look at that. There was a mild anion gap metabolic acidosis in this case, and a respiratory acidosis. So we can go through that. But again, we don't call this superimposed. We don't say superimposed respiratory acidosis. We just say the patient had both, 2 different acid-base disorders or 3 different acid-base disorders. We just keep using the word and, or you can say plus if you want. But don't use the word superimposed, because that sort of implies also temporal addition, that one came before the other. So just use this, just say they had this plus this or this and this. It's far more straightforward. And you never know anyway what came first, unless you have the numbers sequentially in the patient's chart. So again, calculate the anion gap. Here, the anion gap, you're going to have to use the 20. That's the other thing you have to recognize, that in the presence of high triglycerides, you can't use this 5 to calculate the anion gap because it's not a real number. So you'd have to use this. And remember, the total CO2, if it was measured correctly, would likely come back around 21. It's around 1 higher than this because it's 0.03 times 37 higher. Okay. So, you know, again, if it's a man, the bicarbonate fell by 5. The PCO2 didn't quite fall by 5. Of course, we don't know what it started at. Let's say, you know, let's assume because it's a female, what the numbers are, the bicarbonate, let's say, started at 23, it fell by 3. If the PCO2 started at 38, it fell by 1. So that's the reason for saying there's a mild respiratory acidosis. And that confuses some people. They say, how can you say there's a respiratory acidosis if the PCO2 is 37? And the reason is the PCO2 should be 35. The PCO2 should be 3 less than the starting PCO2. Remember, it falls roughly as a compensation, roughly what the bicarbonate fell by. So if the bicarbonate, let's say, started at 23, fell by 3, this should fall by 3. And if the starting number in a female population statistics is 38, it should be 35. So there's a little bit of a mild respiratory acidosis in addition. 2 acid-base disorders. This plus this, not superimposed. So it's a mixed disorder. The reason for that is not clear. We don't have any clinical reasons for that. So marked discrepancy here. When your mind sees that, it should set off a red flag. You can never have this. So again, why is the total CO2 so different? It's called pseudo or factitious. This should be an O here, hypobicarbonatemia due to the elevated triglyceride. And it turns out that light scattering due to chylomicrons and VLDL particles interferes with the total CO2 measurement, because in most hospitals, it's an optical measurement. And if you want, the references here, first described in 2014. So it's already been known for 9 years. It's quite some time that this became apparent in the literature. And as far as the method itself, typically when the lab is measuring the total CO2, it takes the solution. The machine takes your blood, adds a very strong acid and makes carbon dioxide. And then the carbon dioxide diffuses across the membrane and then goes into another solution with an indicator dye that measures the pH. And so it's an optical measurement, and then it's converted mathematically into the total CO2 measurement. And this optical measurement is interfered with chylomicrons and VLDL particles that you typically see in hypertriglyceridemia. Now, you can clear the serum with this substance called lipoclear. It's a liquid polymer that decreases lipemic serum, or you can centrifuge the blood. If you tell the lab to do that, if you see this, then the discrepancy will go away. It turns out also that sodium chloride are also decreased with increasing hypertriglyceridemia. So the suggestion now is either you get a blood gas, and you'll know the truth. Venous typically is all you need, and you see what the calculated bicarbonate is, and then you use that. Or if you don't want to do that, you can ultracentrifuge the serum or use the lipoclear. Tell the lab to use the lipoclear. Hopefully they'll know what you're talking about. Ideally, you could also use an ion specific electrode for total CO2 if it was available in the clinical lab, but it's not. So the simplest thing is, if you don't want to go through all of this and you get this huge discrepancy between the total CO2 and the calculated bicarbonate, just use this. And if you have this only and no gases, you should always look at because this number may not be less than 5. I mean, less than 5, there's obviously something going on. You never see this in a patient who's doing relatively well. Patient should be extremely sick. Let's say this was 16 or 17, though. You might not pick it up. But the clue is, from now on, the simple thought is any patient who's severely hypertriglyceridemic, right away your mind should go, is the total CO2 correct? Even if it's 20, you should be asking, is it correct? And the only way to do this quickly is to get a venous gas and see if they match up. If they match up, fine. But from now on, any hypertriglyceridemic patient, you get back the electrolytes, you should always, 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 in a knee-jerk fashion, say, is the total CO2 correct? And then you tell the other doctor why. They'll say, why are you asking? Because the patient's hypertriglyceridemic and it's potentially interfering with the assay. Now, if it's not, that's fine. But the only way to know is either to clear the blood, as we just discussed, centrifuge it down to get rid of the chylomicron and VLDL, or get a venous blood gas. And then you'll know immediately, because this number isn't affected by the high triglycerides. So this is sort of an interesting phenomena, and it definitely could be on your exam. And once you know it, you just don't forget it. It's pretty easy to remember. So I think I'll stop there for today. Are there any questions that anyone might have on these cases? Okay, so the teaching point for the first case is beware of metabolic alkalosis in a patient with a bicarbonate or carbonate load, in someone with a low eGFR. And also, if someone is on a source of bicarbonate or carbonate and they're on kexalate, be careful in those patients too, because they have a much greater chance of generating sodium bicarbonate in their duodenum and absorbing the bicarbonate. And then lastly, if a patient has a high triglyceride level, check and make sure the total CO2 is the number that is reported, because it may not be correct. Okay, everyone, I think I'll stop there. And if no one has any further questions, have a great day.
Thanks, Dr. Kurtz.